Great. Welcome back, everyone. Sorry about that. We did not have audio. So it is Thursday, February 16th, and you're in the House Healthcare Committee, and we are taking up the governor's proposed fiscal year 2024 budget on dental rates. And we're going to start off with Patrick Gallivan, the Executive Director of the Vermont State Dental Society. So welcome.
Thank you very much, Chair Houghton and members of the House Healthcare Committee. It's a pleasure to be here today. Thank you for including the Vermont State Dental Society in the deliberation on the important topic of Medicaid funding. The governor's proposal to increase the Medicaid budget to 75% of commercial rates, we believe, will be a great step forward for the program and truly impact access to care. By way of introduction, and for the record, my name is Patrick Gallivan. I'm the Executive Director of the Vermont State Dental Society. I've been with the Society for 3 years. I'm so pleased to be joined virtually today by two dentists, providers prepared to share their stories. Their insight we hope you'll find valuable as you make your decision. The first is Dr. Steve Ray, a practice owner from Norwich, Vermont, and the current president of the Vermont State Dental Society. And then Dr. Gary Davis from Timberlane Dental in South Burlington, Vermont. After testimony from each, I will wrap by sharing some thoughts on why this important increase will have an impact to access to care in our state. So if it works for the committee, I would turn it over to the dentist for insight.
Great. Welcome, Steve. Is that Steve or Gary? Gary, sorry, couldn't see the screen.
Having some issues not having a good email address, and did you email?
So we'll let Claire connect with Steve and we'll have Gary start, if that's okay.
Introduction.
Yes, well, and we're going to do some quick introductions of the committee, just so you know who you're talking with. So, Bobby, would you like to start?
Yes, I'm Bobby Farley-Trubio from Barnet, and I also represent Waterford and Reigate.
Alan DeMar representing Enosburg and Montgomery.
Alyssa Black, and I represent Essex. I think I might represent you.
That's true.
Lori Houghton from the city of Essex Junction.
And Topper McFarland from Barrytown. I represent Barrytown and Williamstown.
Lauren Cordes, I represent Lincoln, Moncton, Starksboro, and Bristol.
Daisy Rebecca Winewski.
Leslie Goldman, Wyndham 3, Rockingham, Westminster and Brookline, the Bells Falls area.
Art Peterson, I represent Clarendon, Wallingford, West Rutland, and a part of Rutland Town.
Great. So, Gary, if you can introduce yourself for the record and then tell us your testimony.
Yeah, so I'm Gary Davis. I'm a pediatric dentist with Timberlane Dental Group. And I also very much appreciate the opportunity to be a part of this today and to speak again on this very important topic and hopefully answer whatever questions you folks have that maybe can provide information to help make the best decision to create the best outcome. So thank you very much for opportunity to be here. I would first throw it out to say I think I could best utilize time to answer questions specific to Timberlane, to my own situation, to children's dentistry in general. I'm a pediatric dentist. Or I can kind of roll with a bit of a presentation with some thoughts on things and then field some questions afterwards. But questions right off the bat, or
I think what we'll have you do is provide your testimony, tell us what you do, how you think this will help, and then we'll leave time for some questions.
Yeah, sounds great. So I'm a pediatric dentist with Timberlane Dental Group. Just background on our group. Timberlane is a large group practice. We have 4 locations in Chittenden County. We're made up of 7 pediatric dentists, 3 orthodontists, 8 general dentists who function in our practice as adult dentists, and 2 periodontists. So we're one of the larger privately owned group practices in New England. Our practice has been in existence since 1973, so we're celebrating 50 years. I personally have been part of the group for almost 30 years. Besides being a part of the group and in the trenches for the last 30 years, when I joined the group, there were the 2 original pediatric dentists in the group. I joined them. They've since retired. So I've been a part of recruiting 6 additional pediatric dentists to our group over the last 25 years or so. So that's also been an interesting role besides treating lots of kids to help bring new providers and specifically providers for children's healthcare into the state. Our practice has been the largest provider of services for kids covered by Medicaid for the last 50 years, of which I've been a part of for almost 30. And we continue to have that position in the state where we see that we are the largest provider of services for kids covered by Medicaid. So every day of my career, I've been in the trenches, treating lots of kids and treating lots of kids with different challenges, and loved every minute of it. But this is certainly a passionate subject for me. So I really appreciate the opportunity to be here. I think almost it's kind of a great snapshot of what a pediatric dentist might do and what our practice does would be to tell the story as to how I ended up getting the invite for this particular meeting on Tuesday. I was in the operating room at UVM Medical Center as a pediatric dentist. We treat folks under anesthesia that need dental work, and they're typically young kids with a lot of dental cavities or kids with different health issues that require dental work to be done under anesthesia, or adults with special needs as well. And the day's typically very busy. There's very little time in between cases as we're turning over one case and then prepping and getting the next case going to check in on email or check in on a text message. But I happened to grab my phone in between my first and my second case and saw a message from Claire that threw out an invite for some version of a meeting related to healthcare and the proposal for additional funding for the Medicaid program. And without even knowing who the meeting was with and who else was participating, I quickly responded back. I'll figure out a way to be there. It's terrific to get this opportunity, and thank you very much. Then I kind of rolled from that quick message into my next case. And my next case is a classic example of the types of things that we deal with and the types of situations that can be really significantly positively impacted by a change like that's being proposed. So my second kid, without too many gory details, was a 4-year-old child with autism that had a whole bunch of dental cavities that required fixing under anesthesia. It's a kid that came from a rural part of Vermont. We see referrals from all over Vermont, as well as upstate New York and New Hampshire and at Timberlane. And a kid that came from a rural area where they had trouble getting into a dentist early. The pediatrician noticed some obvious cavities while doing an exam on the kid and referred them over to our office. After getting to our office and determining what we needed to do, there were a multiple month wait, which is typical to get the patient on our operating room schedule. Shortly after the initial visit, that child ended up coming back to the office because one of the teeth that needed repair ended up with an abscess. So the kid had swelling and some discomfort, came back for an emergency visit. The operating room visit was still many months out, so we put the kid on antibiotics and referred them to an oral surgeon in the area, where the kid got put to sleep in the oral surgeon's office and had a tooth removed. There were multiple other teeth that, of course, we kept our fingers crossed wouldn't end up in the same position before we got a chance to get the kid into the operating room to fix them. About a month before the operating room date, the kid had another tooth that ended up getting an abscess, came into the office. We put the kid on antibiotic, and we were able to, with a couple of rounds of antibiotic and a lot of palliative type treatment, keep things quiet enough to not have to send the kid for a second round of general anesthesia with the oral surgeon and nurse it along till we got the kid into the operating room. In the operating room, of course, addressed all the kid's dental needs. But as this case was sitting in front of me and I was thinking about the situation that evolved a few minutes prior to the case, I thought how in this situation, that wait time, that lack of access to care created the need for additional visits to our office, for the hardship that was created for that kid with a couple of abscesses that developed, with the need for additional general anesthesia exposures or the need for an additional anesthesia exposure because of the referral to the oral surgeon that was necessary, the stress that creates on the family having to drive from a long way to get to our office, and then to the oral surgeon that was willing to accept the patient, that the stress that creates on the family and the burden that creates on the system for the additional cost of those additional visits and the general anesthesia exposure. To me, what was in front of me was a very typical situation. But as the day evolved and it became more clear to me what meeting I was going to attend and what the issue was at hand, my my enthusiasm grew as I considered what's out in front of us, which is the opportunity to make a significant difference in the access to care and the opportunity to create a better path for kids like that. And those are the types of kids that I've seen every day of my career. By incentivizing more folks to participate with the potential additional funding, and for strengthening the relationship with practices like ours that are already doing a large part of the work, to continue to do that and to incentivize us to add more providers to do even more in the future. And this is a really, really important issue and a really exciting time to potentially make an impact that's going to be, that will last into the future. I'm happy to pause there and entertain a question or two, or kind of continue with my nonsensical monologue here.
I think we'll stop there. We have a couple of questions. I appreciate that story. It definitely helped to paint a picture of what you work with every single day. So Art?
Yes, thank you, Doctor, for your testimony. My question is one that I always have in these situations, and that is around the rates and how they affect you. And it's always something I seem to have a hard time understanding. So right now, the child that you talked about is maybe on Medicaid. So you do all this work and then you get paid 50% of what? And this is where I get confused as to what the rates are. And I can't imagine not just getting 100% of what you do, but that's what I don't get. And can you talk me through that?
The Medicaid reimbursement schedule currently is about 35% of our usual and customary fees.
All right. Okay.
And decreasing because of the length of time that it's been since we've seen a fee increase, which is close to 15 years or so.
So when you work on this child, you're in fact losing money. The practice is losing money. Is this what it is?
Correct, because the typical overhead in a dental office might be roughly 60%.
Does 75% cover everything, or are we still losing money? And how does that work?
It's a significant increase, significant enough to, and we spend a lot of time in our practice because of the large group of pediatric dentists that we have and the large bulk of patients that we see that are covered by Medicaid. This is kind of a monthly conversation at our practice meetings. And, this is the kind of increase that will open up, not only incentivize folks like us to continue to participate at the level that we are, but potentially open up opportunity. But I really believe it would open up opportunity for additional dentists to join the program and participate more, which has a trickle-down effect on an office like ours. As a pediatric dentist, we kind of have a dual role in the world of dentistry. We're primary care providers for lots of kids, meaning they come to us as their primary dentist. We see them at young ages. We hammer a lot of preventive information and opportunity, provide them a lot of preventive opportunity, and hopefully see them into their young adult years where they have minimal to no dental needs and have a healthy relationship with the dental world. We're also specialists where we get a lot of folks referred to us. And the more general dentists that participate, the more we're going to be able to focus our care on the specialized portion of things. And we're going to be able to get more kids that have needs in more timely and get them to the place where they can get treatment more timely and avoid a story like the one I described. So yes, this type of increase is a significant enough increase to incentivize us to continue to participate heavily, to continue to add more providers, which we've been successful at. And I absolutely believe incentivize more dentists to participate, which will spread out folks, get them into offices earlier, allow us to focus on what dentistry is really about, which is prevention, and minimize the financial impact on the program when you got more healthy kids in dental homes at earlier ages, and allow us to do some of the specialty work that is difficult to get to because the burden is that there's a lot of kids to take care of.
Great, thank you. We have two other
That's a
questions.
long, I think that's a long-winded version of answering what you asked, but is that sufficient?
Yes, that was helpful. Thank you. So we have a couple more questions and then we'll move over to Dr. Reyes, Lissa, and then Topper, and then Leslie.
Yeah, I just, piggybacking on what Art said, and maybe for frame of reference, I don't know if you're going to know the exact answer to this. Can you give us an idea of what the current Medicaid reimbursement would be for just say, like a routine pediatric exam? Come in, I guess, clean and you look at their teeth. I don't know, do they still do fluoride?
Yeah,
What
oh,
are
yeah.
what are they currently reimbursing?
The dollar amount,
Yeah,
that I don't know off the top of my head.
okay.
That's fine.
But what we do look at regularly is what in terms of what that lies percentage wise based on our usual customary fee and various things, because those percentages matter because of course we're constantly doing figures on overhead and cost of doing business and those kind of things. So I know when I say 35%, I know that's an accurate number. What the actual dollar amount is, if you ask me what that is for in our usual and customary fees, I don't know. I don't know that only because those charges are put in by the hygienist or by the assistant and then checked by our collection folks and our insurance folks and those kind of things. And the good news for me is that I'm in the trenches doing the work, and then a lot of that management is done by other folks, very qualified folks.
Great. Thanks, Gary. Topper?
Yeah,
Yes, Doctor, thanks for coming in.
yeah, absolutely.
Have you talked to other dentists in your organization to see if they would participate in the Medicaid program?
Yes,
If
absolutely.
the increase was made?
Absolutely. We again, we have a kind of a unique position in the community because we see a lot of referral patients as well as, have a large primary care practice. And so certainly we're connected to a lot of the general dentists in the state that refer us patients, as well as we practice with 8 general dentists. So yes, I have. And I really believe that, what we're talking about is a significant increase to the point where folks are going to be more interested in participating. And there's other details of the potential funding, I think, that are particularly attractive, which is the concept of tying it to a percentage of Delta Dental, which really allows the fees to stay current over time, which means you're not going to see a single increase, which gets watered down over the next 15 years where you don't see another increase, and what might bump fees to 50 or 60% of usual and customary end up back at 30% 8 or 10 years from now, which, the incentive for folks to participate is that it's a sustainable model that will see the fee increases over time. So if you take in new patients and you're seeing those new patients and additional new patients 5 years from now and 10 years from now, there's a mechanism for those fees to stay current over time so that you're not in the same situation that we're in now. And I've been around long enough to see the days when the fees were 50 or 60% of our usual and customary and have them, trickle down to 30% over time without an increase. So nuances like that are particularly, I think, attractive for folks to participate because it's not just a potential change for this year. It's a potential change that's sustainable over time because those fees will move along with Delta Dental, which will also help move along with the increasing costs that we see every year in terms of, managing our practices.
And that's a really good point. I'm glad you brought that up, that this is normally when we have DVA come in and do rate increases, it is a one-time increase. So we're going to increase it to this dollar. What this proposal is 75% of Delta Dental. So if Delta Dental goes up next year, we'll see a corresponding increase for here. So thank you for that. And I think, Patrick, you wanted to make a comment?
I just wanted to add to the representative's question about are we prepared to bring on more providers? We will absolutely partner with DVA. The Dental Society represents about 80% of market share of dentists in Vermont, and we stand at the ready to promote this program fully because it matters to access to care.
Yeah, great. And we'll hear from Patrick again at the end. So Leslie, you had a question and then we will move on to, is it to Dr. Reyes or Reyes? We'll move on to after Leslie's question.
Yeah, thank you. I just want to clarify two questions. One for you, Lori. On page 58, is the tie to Delta Dental ongoing? I'm not seeing that in the language. I'm just...
Right. So because it's not a dollar amount, it's a percentage.
But
So
I'd say that
applying
percentage is...
with 75% of Northeast Delta Dental 2023 commercial rates. You know what? Actually, it doesn't. So we'll ask Diva that question.
Yeah.
Thank you.
Yeah, I think that needs clarification.
Okay.
Thank you. My question, Dr. Davis, is about how to prevent children from getting to the point where they need you. Not the primary care part, but the secondary care part. And what can we do to support, I'm thinking social determinants of health, sugary drinks, whatever, that we could do to protect protect teeth for, that.
Yeah, it's a great question because, dental cavities are the number one childhood disease in the world and primarily a preventable disease. And the model, the key is early visits and early preventive measures, and increasing access to a dental home early is a proven method of reducing disease. With the model is the anticipatory guidance model that the pediatricians have operated under for years. It's seeing kids at 6 months, 12 months, 18 months, and preparing the parent for put protective measures in the plugs and baby proofing the home. The dental model for that is a proven model, and it means getting kids a dental home early, and a lot of active prevention and coaching that's applied will really go a long way. And so increasing access to care for folks early on is a really, really important thing. And clearly this is a financial commitment to something like that, without question.
Thank you.
Absolutely.
Great. Thank you for your time and your work.
Yeah.
You're free to stay on and listen to the rest of the testimony, or if you must leave, we understand that. So
no, I'm interested to hang around, and
okay.
I'll mute and then unmute if you guys want me to at some point.
Okay, great. Thank you.
Yeah, thanks for having me.
Good morning, Dr. Reyes. How are you?
Good morning. I'm well, thank you. I wish good morning to all the members of the House Committee of Health, and I can say that I can understand that your jobs are overwhelming. I can only imagine how many of these you go through.
Thank you for that. So we are happy to have you provide your testimony, and then we'll ask some questions most likely at the end, if that works for you.
Okay, yeah, that sounds great. So I'll just start by giving my history and background. So I'm the current president of the Vermont State Dental Society. I got involved shortly with the executive board about 3 years ago, and it's been a wonderful experience. My background is I originated in the U.S. Public Health Service out of dentistry, graduating dentistry in Michigan, and was sent to Alaska on a loan repayment stint, and enjoyed the public health service aspect so much. I stayed 21 years, retired with them as a Commissioned Corps officer retiree, and made my way to the Upper Valley of Vermont in 2015. And so when I first arrived to the area, I am a self-admitted business derelict, and I just did business as usual, like you would in the public health. Opened the office, opened the faucet up to as many patients that needed care, because that's where my heart was with public health, and got myself in trouble really fast because the percentage of Medicaid patients that we were treating increased in magnitudes. And I learned the hard way that you could not really make a practice work in that fashion, because it wasn't really even a break-even venture with the Medicaid funding at the time. So I regrouped and realized that I could continue to make it work. We continue to be, as with Dr. Davis, one of the largest Medicaid dental providers in the state. And we do that with payer mixes. Essentially, there's a sort of a payer mix that makes it doable. And I feel like it's necessary because there are children that need help. They need this care. So we find a way to meet that need. So I would say if there's one thing that I would emphasize most this morning regarding this particular topic for the governor's proposed budget increases, access to care. That's going to be, I think, what gets accomplished in this increase, and or at least that's the hope. If you look at studies in states where they've taken this approach and actually increased the Medicaid funding, we have examples of that Jamie Freeman, I'm sure, will share with you, actual studies that were done. But it generally has shown that all states that have approached in this fashion have increased the provider participation. And that's what Vermont really, really needs. In the interest of brevity, I just want to give a couple of examples. We have a really difficult time right now having a child access care with oral surgeons. Dr. Davis mentioned that he had a patient access care in that fashion. We don't have the option here in the Upper Valley because no oral surgeons will accept Medicaid as an insurance. And so we send them to Dartmouth Health, and they are absolutely overwhelmed. Sometimes they're up to 9 and 10 months out. So it's really challenging for these kids to get the help that they need. I'll give you another just anecdotal example because it makes it real life. We had a kiddo who had a molar that was, the pandemic was devastating to oral health with children. I'm sure all of us have experienced some of that, but this kiddo had a permanent lower molar that was going to be very challenging to restore and needed what we call endodontic care or a root canal. He was covered with Medicaid, and we tried everything, moved heaven and earth to try to find him a provider that would help, because the parents weren't willing to accept that a 12-year-old needed to lose a permanent molar as the only other option. They were unable to find anyone in the state of Vermont, New Hampshire, or Massachusetts that would help with the reimbursement that they would receive. So they went down to mid-Massachusetts and found a general dentist, not a specialist, who was actually willing to help. Seeing things like that is sad, but looking at it from a public health service lens, which is what I have, is probably my biggest disappointment is we work, struggle, and fight to help children with oral health and try to work on the preventive aspects of oral health. And the children graduate from a pediatric practice at age 18 by necessity, they're adults. And these children that graduate from my practice, after we've worked really hard to get them to a good state of health, leave, and they're unable to find a single solitary provider that will accept their insurance to continue their oral health care. They'll call our office in desperation. We give them names, but it just the trend has been going the other way. And so it's really disheartening for me to see them graduate and then be unable to find continued care once they reach that status. So those are the things I wanted to talk to the committee about in terms of how important this increase will be, I think, to reaching these children and providing access to care. Beyond that, I think we have a challenge in pediatric dentistry reaching as many children as I wish we could. And there's a lot of general dental providers that, again, aren't willing to take this as a reimbursement mechanism. And so I think if we had more participation, we would have greater access to care, and these kids would start getting the access that they need. And so that would be my answer to the question that was asked previously in terms of how do we prevent this? Gosh, by the time these poor kids are in desperation and have 4 quadrants of dentistry, 15 out of 20 teeth that require restorative, there's one way to do it and do it in a manner that's humane, and that's doing it while they're asleep in an operating room, which increases the cost by magnitudes. So I'd love to see them get ground level care prior to reaching that level of disease. I am, again, a self-admitted business derelict, but I heard you ask Dr. Davis a question about to get a general feel for reimbursement and what this would mean in terms of numbers. One example, I ran out to my business manager who does know what she's doing.
We saw that. We figured you might come back with an answer. Thank you.
Yeah. She said our fee for a prophylaxis of fluoride and an exam is $240. Of that, Delta Dental will reimburse $197. Vermont Medicaid will fund $77 of that amount. So out of a $240 fee, they will reimburse $77.
Thank you for that information.
Yeah, so that gives you a bit of a litmus test there to go on. And again, it's not a break-even venture for most of us. Unless you have, or you're fortunate enough to have everything completely paid off, there are, it's just the cost of doing business.
Yeah.
I'm happy to answer any questions from, again, the Public Health Service lens that I can.
I think we have
really appreciate you considering this because I think it will have a tremendous impact.
Great. Thank you for taking the time and providing your testimony. We do have a couple questions. Daisy?
Hi, Dr. Reyes. First of all, thank you for your service to Alaskans. I grew up in Seldovia where we have, you're laughing, so I think we have an outsized portion of dentists in the community. Do you know what number of dental offices here in Vermont within your membership have formal relationships with FQHCs or MOUs?
I don't know what percentage do, honestly. I don't have that particular number. We certainly work closely with a number of HQFCs, and patients come from a variety of different locations, particularly in areas with extreme access to care issues such as the Northeast Kingdom.
Yeah.
And so again, that's sort of why, we're still 40% Medicaid in this practice. And the reason we are, as I said, we just can't turn down referrals from HQFCs, from hospitals, from pediatricians and others that say these children need help. We just need to do what we can. And we've been able to sustain at that level. But I got way beyond that when I first came to the state. I had no idea that it was going to be that different. In Alaska, it wasn't an issue.
I have a question. So we hear a lot in our committee and quite frankly, in every committee about our workforce issues in Vermont. So would the increase in these rates allow the current dental workforce to increase their capacity? And if not, and it would require us to hire more dentists to increase access, is there a workforce to hire in?
So that's an excellent question. And I had it on as one of my bullet points here. So you led right into that. When I was looking for a place to relocate to with our family of 5 from Alaska, we did look at that as a measure in terms of what the Medicaid reimbursement rates were. Or Medicaid funding, how healthy that was. And so I do feel like that weighs in on a decision of a provider in terms of where to settle. When you look at essentially pair mixes, if you are interested in going to an area such as the Northeast Kingdom, that's going to be something that a proposal, a potential provider is going to look at and assess. I can't say with absolute data, but I can certainly say empirically that I feel like it would lead to an increase in providers in the state, an increase in interest in coming to work in the state.
Okay, thank you. Any other questions for Dr. Reyes?
Only thanks.
Yeah, so thank you. And again, we appreciate your time. You're free to stay. We're gonna have Patrick come back up and sit with us and provide some more data.
Can I throw one additional comment into what was just mentioned with Steve? Just is that acceptable?
Yes, please.
Just I think speaking from the standpoint of having been involved in recruiting 6 additional pediatric dentists to our group over the time period that I've been here, which is as recent as we added another provider last summer. When you're providing healthcare for kids in the state of Vermont, that conversation always comes up because of the large percentage of folks that are covered by the Medicaid program. When we've recruited and we've talked to potential candidates, which we've done on every 3 to 5 years since I've been here, that's a conversation that comes up every time, and because they realize not having a dental school in Vermont, not having other avenues for a lot of kids to get seen, a large burden falls on the pediatric dental population in the state to treat kids with all different backgrounds and all different sets of needs. And it's a conversation that comes up with every potential recruit in terms of the large number of kids covered by Medicaid that exists in the state, that we see how we've managed that portion of our business. And I certainly would speak to that from the standpoint that I think this would go a long way to continued recruitment, because we've been successful working uphill a little bit in that arena. And I think this would make a tremendous difference when we re-engage the next pediatric dental candidate, maybe to replace me one day. But I would speak to that, having had a hand in the recruitment of 6 other pediatric dentists over the last 25 years or so, that it would go a long way towards that conversation. They realize, folks realize that when they're coming to Vermont, it's a relatively unique situation compared to other locations in New England where there might be a dental school that handles some of that. So yes.
Okay, thank you. I think we have one more question and then we are going to move to Patrick.
Yeah, I'll be as quick as I can here. So I understand how a dental practice works. This is a question for either or both of you. Do you, and not to delve into your personal finances, but do you get paid hourly or do you get just a set weekly, monthly fee as a dentist, as a particular dentist in a practice, no matter how many Medicaid versus commercial payer patients you see, and it's spread across the whole practice, so everybody gets a salary based on that?
I'm going to ask Dr. Reyes to answer that question, if you don't mind, because you talked a little bit about when you first came in and took on a lot of Medicaid patients, and that wasn't necessarily great for your business. So you do not have to provide salary information.
No.
You can just give an idea of how it works.
No, I'm happy to share that. So, and you bring up a very interesting point. So to answer that question directly, it's based on the funding that we get per procedure that we do. And so ultimately it depends on what procedures are being done on a day-to-day basis. Now, your question is very interesting because when I recruited, I have an associate that works with me, a young provider, actually also from Alaska. When I was directing the residency program, I recruited her, and here she is, and it's been amazing. But she had a lot of concerns because she realized that she gets a percentage of essentially what she produces on a daily basis. And if that percentage is calculated based on a Medicaid reimbursement, and I don't think you were in the room, but I shared that, like, I'll give you another example just so you have two, because my office manager gave me both. If I do a one surface filling, for instance, a tooth colored composite, the fee is $233. Vermont Medicaid would reimburse $90 on that. So if her percentage is calculated based on the $90 reimbursement rate, obviously you can imagine what that would do to her pay. So what we do here is unique. I recognize that. And again, coming from public health roots, we don't calculate it based on what insurance and what kid and who gets a Medicaid patient versus a Delta patient versus to me, that's unfair. I know there are some practices, some places that do that. We just say we treat kids. And then at the end of the day, whatever she gets paid based on what our fee is, not what we get paid for. And so that makes it fair for her. But as you can imagine, it's not as fruitful for me. But, again, I feel like it has to be fair to young providers that are just getting a start.
Great, thank you for that. All right, we're gonna turn it over to Patrick.
Great. I'm sure you're all asking if an increase to Medicaid funding will have an impact on access to care. The answer is yes. Many of you will remember a task force that DEVA was engaged with back in 2019, which included the Vermont State Dental Society, the Board of Dental Examiners, and the good folks at DEVA. So this conversation's been going on a long time, and even the results of that report talked about Medicaid funding as being an essential to making the program run and work well. I also want to just cite 2 reviews, and I won't get into too much detail here, but I can upload those if you'd like them, Chair. And one is the Connecticut Health Foundation did this, and and it was about children funding, and they found that the number of children enrolled in Medicaid program, at least for one day, grew 18% between 2006 and 2011. 36 and 59% of these children had at least one visit per year in 2006 and 2011. So the numbers definitely went up. The number of children continuously enrolled in Medicaid grew nearly 37% between those same years. In 2006, 46% of continuously enrolled children had at least one visit per year, compared with a 69.5% in 2011. So that rate went up considerably also for children being seen. And again, preventative care is the most important to get things started at a young age. And in another study, the Missouri Foundation for Health Strategies looked at 6 different states: Alabama, Michigan, South Carolina, Tennessee, Virginia, and Washington. Provider participation increased by at least 1/3 and sometimes more than doubled following rate increases. Not only did the number of enrolled providers rise, but so did the number of patients treated, and patients' access to care as measured by the number of enrollees using dental services also increased after the rates rose. So those are 2 examples from 2 separate studies. I just received another one this morning that I haven't read yet that I will also forward along later today. Medicaid programs are offered differently in each state, and we know that. According to the Health Policy Institute, which is part of the American Dental Association, Vermont providers are among the highest in the nation for treating Medicaid eligible patients, and that's a credit to the dentists in Vermont. Our dentists want to treat Medicaid patients, supporting Vermonters most in need. We do have a program that's broken and needs attention, so we can keep these providers seeing patients and encouraging others to join as well. We know that improving valuable Medicaid program that improves Vermonters' access to dental services will impact overall health care in a truly positive way. And a reminder, good oral health is a gateway to overall health and well-being. The Vermont State Dental Society stands ready to partner with DEVA to publicize adjustments and encourage even more participation among our members. So thank you for your time.
Great, we have a couple questions, Tucker.
Could you tell us how you arrived at the 75% rate?
We didn't actually. That was DEVA. DEVA was the they were the driver, and they did mention to us, and we quickly said yes.
Well, and we'll have DEVA come in and have them answer that question.
It's a good question, though.
Leslie, can Patrick answer the question?
Yeah, if that's okay. We're thinking about alternative payment models in other arenas, like, capitated payments. So it would be like a monthly payment kind of thing. Would that apply in dentistry? I mean, and you may not have ever thought about this, but it just occurs to me, if you're doing all this well-person care, and that maybe we need to think about the population in a different way.
Yeah, and I would defer actually to the dentist if they had any comments on that, any thoughts?
It may be way beyond anything you've ever heard of. And please say, I don't know.
I think for this one, we'll
move on.
Put that out there and.
But I would love to see that as prevention.
Right.
Yeah, it's a DEVA question, and
let's.
But just so you know that's out there, and there are conversations about capitated payments for primary care, and you keep mentioning primary care from the dentistry point of view, and it's like, wow, that's really interesting. So, thank you for your work,
Patrick. Do you have any? So based on the fact that this would, if this is accepted, 75% of Northeast Delta Dental, can you give us any numbers on how this will impact access, other than just saying it will increase access?
I don't have a number. I would be making up a number if I did, honestly, Chair, but I know that based on the studies, it clearly has worked in other states and other programs, so we're confident.
Okay.
And anecdotally, I can tell you that our dentists are, they want to treat more patients, and if other people that may have you could ask Eva this question, but a number of providers have decided they just can't make it work
Right.
in their business models. This might get them to rethink that question, come back onto Medicaid, which will take some of the load off of some of the providers that are taking that.
Right.
So that's our belief that will happen. It's going to take some encouragement from us as well, which we're fully prepared to do.
I will, if I could just answer a question on the 75th percentage calculation. What was done and what was specifically recommended by the ADA, it's been a stretch, 2005, I believe, was the setting the funding at 75th percentile of regional dentist fee average. And so this was done in Michigan. I'll just give you some numbers just as an example. They did that. The initial year of the reform, they had a 21% increase in enrolled children using services. 2 years following the increase, there was a 29% increase. And then in 2006, it was a 30% increase. And then the percentage increase overall was 43%. The enrolled providers before this started was 769 dentists in the state. 2 years after the reformed funding, there was 1,624 dentists. The most recent year was a 1,926 dentists that were enrolled. That was a 150% increase in dental providers.
Wow. Those are some impressive numbers. Thank you.
And the study is we can make sure everyone gets a copy of that.
That would be great. If you can send that to Clara, that would be very helpful.
Certainly.
Thank you. Before we go to the healthcare advocate, does anyone have any more questions for anyone that we've been talking to? Great. Thank you all very much for your time.
We appreciate the opportunity. Thank you.
Yes, thank you. Mike, you want to come up?
Good morning.
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 Mike Fisher, healthcare advocate. In case you've never met me before.
Who are you?
That's not possible.
Well, so let me just start with a straight on support for the proposal from the administration. We join with, the dentists, the people who have spoken before us about the low reimbursement rates, and certainly join around the tremendous challenges Vermont people on Medicaid have in finding a provider. It's a crisis. Though I will also say that we do get a lot of calls from people who are on Medicaid who can't find a provider. We get a lot of calls from people who are on Medicare who can't find a provider and who can't afford. We get a lot of calls from Vermonters. This is a problem that is well outside the Medicaid boundaries, though it's good to see this proposal addressing Medicaid. I would love to talk about ways to address the issue beyond Medicaid, but I'll stop myself with that statement. I have ideas. One of the hardest calls that my advocates get. I'm in pain. I've been in pain. I can't find a provider. And sometimes, and Medicaid has identified a single individual in their shop to focus on that. And that has helped. But sometimes, despite the FQHC network that's out there to provide care, we do have cases with people who are in pain who cannot find a provider. Hardest call one of the hard calls for my advocates to deal with. So very much appreciate this proposal. But I want to bring a concern, of course. Let me also join in the conversation. I appreciate the questions about looking for some kind of assurance that this rate increase will result in more providers taking Medicaid. And I appreciate the testimony we just heard. There's lots of evidence out there. I got to say, I continue to have those same concerns. Because the testimony was so clear just now, I think the thought that comes to my mind is that it would be good to keep an eye on it.
Yeah.
It would be good to have I don't know if it's 2 years or, a year, like, okay, we've done this. What's the impact? How many dentists? Be good to keep an eye on it. It'd be good I wish we could find a way. I can't think of a way to hold the dental provider community's feet to the fire on this. So I can't think of an idea of how to do that, but maybe keeping an eye on it is the way to do it. But let me raise a concern. Imagine you have, $4 in your pocket a year ago, and you need to go buy eggs. $4 a year ago, you could buy eggs. You could buy a candy bar too.
And you'd end up at the dentist.
And then you need to go to the dentist. So fast forward to today, inflation, you got $4, you got the same $4 in your pocket and you can't get your eggs. I don't know, what do you need, $6 to get? Yeah, I know everyone's talking about eggs, and so I used that example. But then I'll give we did just a little bit of research, let's make someone up. Anna is 42 years old. She's, she has a child, and she hasn't had access to dental care in a long time. And, but now she's on Medicaid, and she's living under the $1,000 cap.
Let's stop and make sure everyone understands that.
No, I don't.
What the $1,000 cap is.
So currently in Medicaid, we provide services up to $1,000, other than, I think, a cleaning. And so cleaning is outside of the cap.
It's like a deductible, almost. Not really, because you're not paying it. So you can go so many times till you get to $1,000, and then you pay. Yes, and that's for adults, not for children. Correct?
Not for children.
Okay.
And under this proposal, I very much support it. Under this proposal, they are eliminating the cap for the disabled population, which I think is a great move. I would ask the detail. I have yet to see a description of how the disabled population is defined. So I'd like to understand that better, but support the elimination of the cap for that population.
And so I'm sorry, Mike, to interrupt, but I would just want to make sure we're on the same page. So if you're looking at your budget book, I believe that's number 14. So it's separate from what we were just talking about, correct? So it's the Medicaid dental services for DS and CRT clients is the way to put it in.
I think it would be great to get Diva to talk directly to that. That might be the background to the elimination of the cap.
Okay.
It'd be good to get them to talk about it.
When you say eliminate the cap, that means that all of it's free.
All of it's covered.
All of it's covered.
Yes. Yeah.
Okay.
So Anna can spend $1,000 for her care, and she goes to the dentist and she discovers that she needs to have 9 teeth extracted. Hey, this is not an uncommon story. Our estimation is that if the dental rate was 50%, if Medicaid was paying the dentist at 50% of the Delta dental rate, she'd be able to get that care. $912 was our estimation. So she could get her care. With this rate increase, again, a rate increase I support, but with this rate increase, the cost at 75% of the cost of Delta dental, we estimated to be $1,368. So $368 more than she is supported by Medicaid. And let's remember, this person's on Medicaid, so they're very low income. So we would be struggling to know what to do to support. Hey, that reminds me, I did send a resource page to Claire just now of all of the free, all the low-income dental clinics around the state. I thought that would be useful. That's where we would turn. So there's a resource page that's going up on the webpage.
Great.
that has that information for all of your communities. We would like to propose that we eliminate the cap. We would like to ask you to consider to eliminate the cap for everybody on Medicaid. I honestly, the first question you should ask me is, what does that cost? What are the impacts? And so.
Across the street, will want to know.
Well, I don't know. And so I think that, we have been posing a few questions. A few of those answers came back to me just a few minutes ago. In 2019, when the dental cap was $510, 9.3% of Medicaid recipients reached the cap. And I'm going to give you these numbers, but I'm going to suggest that it makes sense to have Medicaid come and talk about it. 9.3% before we raised the cap from $510 in 2020, we raised it from $510 to $1,000. We raised it. The legislature raised it. Thank you very much for those who are here. So in 2020, big old asterisks about anything in 2020 because of COVID, but in 2020, 1.9% of Medicaid recipients reached the cap. And in 21, we are told 2.993% of Medicaid recipients reached the cap. So between 2019, when 9.3 were reaching the cap, in 2021, remember we doubled the cap essentially, 3%, it does, we would need many more details about average spending and whatnot, but I guess it leads me to want to say, other than a very, very small percentage of us, Representative Black notwithstanding, nobody likes to go to few people really like to go to the dentist. But some people really need to.
In your numbers, the 3%, I mean, we can also assume that that could be higher if there were more providers who were taking Medicaid. So.
Fair enough. What is the reason for it? Is it lack of providers? Is it, I think, so this definition of reach the cap, if I was on Medicaid and the services I needed was $300 more than my cap would provide for, I might not get any of those services, and so I might not show as reaching the cap. So there's lots of nuances to it. I think average spending under the cap would be useful. I think I was about to say sort of seeing the average spending before and after we raised the cap last time. We think the right thing to do would be to eliminate the cap. The right sort of humanistic thing to do would be to eliminate the cap. But I'll also add, it's never good as a negotiating tactic to offer something slightly less, but I'll say it anyway. At the bare minimum, we should increase the cap the same percentage as we're increasing the rates. Let's keep people's buying power at least equal.
Do you know if Delta Dental has a cap? Anyone know?
I hate it. My favorite dental work.
It sort of leads me to want to say.
I think, yeah.
Yes.
I'm sort of processing because, yes.
Yeah.
Yeah, dental insurance is a bit of a different animal than health insurance. It is in many ways like paying ahead for services.
Yeah.
With some nuance to that, but yeah. So that's really what I wanted to say. Now that I gave you a slightly less extreme stance, I'm going to go back to the first one. I hope you'll consider eliminating the cap and evaluating the financial impacts of that and whether how we would afford that.
Overall, though, you just support the increase to the Medicaid.
Absolutely.
Thank you. Topper?
I have a question for all three of you people.
I'm only one.
I really don't care which one answers it. you all talked about people in pain that could not get services. So, do you just stay in pain? Or do you go to the emergency room?
You get addicted to opiates.
Leslie.
I'm going to let.
Dr. Davis, you took yourself off mute, I think, or Dr. Reyes, do either of you want to answer that?
I'm happy to just make a very quick comment, and essentially what the latter of what you said is my experience. The care gets deferred to emergency rooms, and these poor patients they get triaged to the very bottom of the list because dental's never really considered the higher priority. They wait 5 hours in an emergency room setting, and then they're given a prescription, and then told to find a dentist who will accept their insurance. And those poor patients scramble and try to find a place to get someone to help. But ultimately, I've done several lectures at Dartmouth Health to try to educate physicians on how to help. And in the meantime, I'm on call there, so I go in and help, as much as I can. But you're right; that's what happens.
Thank you. Great. Thank you, everyone. We will be discussing this as a committee. We will probably bring Diva back in. We will see if the FQHCs, you know what I'm trying to say, FQHCs want to testify. So we'll be coming back to this. But we appreciate all the care you give Vermonters, and thank you for taking the time today to be with us.